Hello, our fearless host, Eric Storch. All right. Hey, everybody. This is Dr. Patrick McGrath. I am from NoCD and head of clinical services there. I'll let my other friends introduce as well, too.
I'll go. I'm Dr. Allison Solomon. I'm a psychologist specializing in OCD and anxiety disorders, and my practice is 100% teletherapy for the past 4 years with kids and adults.
And my name is Liz McIngvale. I am a board member of the International OCD Foundation and started the Peace of Mind Foundation. We're working together to help bring a lot of these webinars. Dr. Storch was one of my mentors. I am now at the McLean OCD Institute of Houston, and I'm the director there. I've been doing teletherapy on and off for about 2 years, and right now our entire practice has moved to teletherapy as well.
Yeah, and I'm Eric Storch. I'm a professor in Department of Psychiatry at Baylor College of Medicine, where I'm also a vice chair of psychology. With tele, I feel sort of cool. We were doing this back in the late, like 2008, 2009. And I was getting all excited until someone told me that there were some state laws that you had to listen to. And so we put the kibosh on that shortly after in our research program. But over the past couple of years, past year in particular, we've been kind of piloting this for Baylor College of Medicine. And so I have a fair bit of experience in this space.
All right, so as always, we would love to encourage you to post any questions that you have in the live comment section so that we can answer them throughout, whether they're questions specific to teletherapy right now, any questions you might have in the future. We'll do our best to answer them. We may not know the answers to them all, but we will certainly do everything we can. Any questions off the bat, Eric or?
Yeah. So. Great point. And I would love to hear, if you had a couple sentences from our very esteemed kind of panel here, what would be kind of that, the keys or the tips that you would give if you're on an elevator ride up, while 6 feet apart, of course, to someone who wanted to start doing teletherapy, kind of that kernel or gem. Dr. Solomon, do you want to start?
Yeah, great question. I think for me, it's been a learning curve along the way. Even when I had my in-person practice, I still did teletherapy to maximize exposures. For me, I think having interactive screen share, being able to have a whiteboard, being able to interact rather than just screen to screen has been a game changer for me. That's, I think, essential for me.
And I'll give a pitch for a second from the opposite side. As providers, I think we often get asked by clients, like, why would I want to do teletherapy? What would be the benefit in teletherapy? And, we're seeing it right now. I think a lot of people are a little bit nervous, right? Like, I've never done this before. What's it going to look like? And what I'm hearing over and over in the OCD community is the silver lining that people are finding, right, with tele. And Dr. Storch and I work together. We know from our work the cost of home visits compared to in-person visits are usually pretty darn high and pretty big, right? Most people can't afford a home visit, even if they think their OCD would really benefit from it because they have contamination or safe zones in their house or whatever it might be. So the silver lining, especially right now, is that you're kind of getting a home visit for the same cost, right? Teletherapy gives you an opportunity to practice exposures in home environment. And we hear over and over again from residential, inpatient residential, IOP to lower levels of care, that the biggest kind of difficulty people have when they taper down or terminate treatment is practicing these skills in their home environment. And that's one of the really big benefits of teletherapy.
Mm-hmm.
Brilliant points.
I've had better, go ahead, Patrick.
Oh, no, please go ahead.
Just in terms of outcome, I've had better results since I switched to teletherapy than, typical face-to-face. It's been pretty awesome that you get to practice in vivo, in the moment. You can troubleshoot. You can see the patient in their own environment, include family members.
Yep.
It's really flexible.
Yeah. Well, I think in both, Dr. Solomon and McIngvale, you kind of hit on a couple of the benefits. And from a payer standpoint, what we've seen is really a complete relaxing from insurance companies. And then many of us who don't accept insurance, you also have that flexibility and have had that flexibility to operate, which really can help you actualize the benefits that you're describing. Dr. McGrath, thoughts?
I've also enjoyed, I feel a bit more energized doing this, because if I was at the hospital, my full-time job all day, and then now I have to go and see private practice patients, and I'm doing that till 9:30 at night, I was exhausted. But now doing it from home, I can kind of schedule my day out. I can have a little break here or there if I need to. And I feel like I'm taking a little bit better care for myself. And then I think I'm actually doing better for my patients as well.
Mm-hmm. Now, Dr. McGrath, on that note, do you think then it's acceptable to not wear pants as you're doing? Just check.
I always wear pants. I am wearing them now, even. Just so
I am just checking.
Okay.
We did have one of my therapists once who was wearing shorts together with a very appropriate top, and then had to get up to attend to a barking dog, and was discovered. So you have to maintain that professional attire.
Absolutely.
That has happened to me, actually.
All right, the secrets come out.
Pajama pants and a blazer work really well together until the dogs bark.
In some cities, that's actually a style in vogue.
Silver lining. See, once again, you're just setting trends. So it looks like we have a lot of questions. I don't know if we want to hop into some of those. I'll start with the first one. What platform do you use? I've used quite a few different platforms. So right now at our clinic, we use a patient portal called Theranest. And Theranest has its own webcam, own kind of teletherapy component built in. And then, of course, I've also used Zoom. So Zoom is HIPAA compliant if you get the additional healthcare version. And I love Zoom. The last question that came in that we'll answer in a little bit about doing IOP over tele. Zoom is great for that because you can break into groups, you can kind of have different rooms, and it's a really great platform. So those are the two main ones I've used.
Nice. Dr. McGrath, Dr. Solomon.
Similar, NoCD through the app and the work that we're doing, we utilize Advanced MD or AMD, which is our medical record, and we use a HIPAA compliant Zoom through our systems as well too.
Yeah, I've used before. Zoom is my go-to, the healthcare version, but before that, I've used Doxy.me, VC, the ones I use Counsel as my EHR, so I've used the one embedded in that. But most of those other ones don't really have the flexibility that Zoom has as far as screen share, file share, in the moment, breakouts, and all of those. So
right, and I think that speaks to that notion, of understanding the capabilities of really each product to ensure that it works for you. We use Zoom that interfaces with our Epic, and then it meets kind of all the criteria, and I've just found to be exceedingly easy to use. Not advocating for that over another, but within that experience. And I think the seamless flow of it, just requires that practice and getting some experience. So we have another question that's come up of how do you engage patients in exposures, but also monitor their refrainment from rituals. Dr. McIngvale, do you want to give a shot?
I think that. So this is it's hard because this is the thing I would say in session. Even when you're in session with a client, we can't refrain them from ritualizing, right? Most of our clients ritualize mentally as well. And so there's really no kind of way for us to always say, okay, well, if we're in person, you're not going to ritualize versus if you're on the camera. When you're on the camera, you can still see them. So when I do exposures with my patients, they're actually, taking their cell phone or whatever their platform they're using, they're turning it, like they're showing me the contamination stuff that they're touching, and we're still working through it. To me, kind of ritual prevention is more about therapeutic rapport, and it's more about having a relationship with your client where they would be willing to say, like, that's too much, I'm not ready to do that, versus feeling like it's you having to monitor them, because really it's no different than it is in person. So again, if their anxiety levels aren't decreasing, or there might be some ways that we can kind of evaluate or assess whether or not we think they're ritualizing. But overall, I don't think that it I think it's more about a patient being honest. So if you have a patient, for example, that's tapping their feet and, touching and tapping is a part of their OCD rituals, I would encourage them to move the camera where we can see their full body, so that when we're doing exposures, we can help support them the entire way, just like we would in session.
Mm-hmm.
That's Dr. Solomon.
I tend to do the same. I'll also go through kind of a pre-treatment commitment of what's going to get in the way of, you going through these exposures really wholeheartedly, and, what are the obstacles that we can look at ahead of time. And like Liz said, people are going to ritualize if they're going to ritualize, and we can only do as much as we can to minimize that and educate them and build that rapport so that they're able to say that.
Mm-hmm. Yeah. How about Dr. McGrath, thoughts on, we've been talking mostly about video. What about telephone-based services? Any differences, ways your approach, perception of efficacy, anything like that?
I'm more reticent of using just the telephone over the video, only because I'm generally not all that trustworthy of people anyway when they're telling me they're not doing a certain ritual. And I always like to say, I'll believe it when I see it. So I like to make sure that we have a video session going on, because if someone says that I haven't done that ritual, I'd like an example of that to show me that they've actually interacted with the thing. And that's what we can do live. If they say, well, I've ridden an elevator, great, let's go ride the elevator here at the building too, just to kind of show me what you've done and how you've done it. So I try to stay away from just the phone if at all possible.
Mm-hmm. Yeah, I think the other points too, one is, from a billing standpoint, with insurance, you are able to bill at the same kind of time code, but the reimbursement tends to be less. It's a different code for a telephone call. Mm-hmm. And the other is, I think what we're all saying is, while in most cases the tele platform or the video platform allows you to do, as much, if not more, in some cases it still isn't quite the same. And there are instances where it's not a great fit. And we want to be able to kind of use all of our senses to be able to do a complete assessment and engage the individual.
Right.
And I'll also say, I do think there's sometimes that telephone's actually more successful, right? So we have, in particular, we'll use telephone if we're coaching patients through a bathroom exposure. It wouldn't be appropriate for them to their video, right? Like there's certain ethical boundaries that are important, but it's really valuable sometimes to coach them through that kind of exposure if they really need help and assistance, because that's where majority of their OCD shows up. So there's of course situations where you kind of have to weigh it out, but I agree overall I think video is much more successful.
Mm-hmm.
Yeah, I use that with driving, when being on video could be distracting and perhaps dangerous. Driving exposures for hit and run, things like that, if there's not someone or some way of having the video set up, I think phone is a good backup, and it sometimes doesn't provide the same reassurance that can be provided by video in certain exposure situations.
Mm-hmm.
Yeah, that's a great point. And kind of Dr. Solomon, on that note, how do you introduce kind of this element of uncertainty? You gave the example of an harm obsession, where someone's afraid that maybe they hit someone. If you're doing it via whether it be video or telephone, what are some of the tricks to the trade in terms of really kind of keeping that element of uncertainty and pathological doubt in play?
I think it's absolutely easier because I can only see a little bit, so I can, say, I have no idea. I don't feel any bumps. I'm not in the car with you. There you can insert more doubt and more uncertainty, but I think it's really the person in particular. And I honestly have experienced very little difference in my practice from teletherapy to in person. I'll still see people in person if they're within the vicinity and the exposures just are not possible via teletherapy due to privacy or some specific situation. Mm-hmm. But as far as uncertainty, I think I would work the same way that I would in the office.
Mm-hmm. Great. Yeah, Dr. McIngvale, thoughts?
I think for uncertainty, at the end of the day, again, this is where it comes to the patient relationship and the rapport. And I think that, exposures don't always have to be led by us. Oftentimes, I think the best exposures are actually led by our patients, and we're supporting them in that process and kind of helping as we can. But when you think about some of the best self-help books or workbooks or different things, right? Uncertainty can happen without us pushing or prodding, but then we have the chance to either reinforce the fear or the chance to help them conquer their OCD through tele or in person. I don't think it's any different. So I will scroll back just because we had a couple questions that I think we could probably answer quickly. So Nancy asked, how do we screen share over tele? So most of us have talked about using Zoom, and typically the way that you screen share on Zoom is in the bottom. There's a little icon that you can click, and you literally can click share screen. Now, I do think it's really important we talk for a second about HIPAA and some privacy laws around teletherapy. And obviously, Allison, you'll be able to speak to this more than I can with your experience, but make sure if you're sharing a screen that you have your email notifications turned off, that you don't have your email still up in the background, because obviously some of us have patients or different people that might email us about a patient, and you would never want any of that information to pop up or show up and or to be in the background. And then the same thing goes for tele. I think it's really important when we do tele at our clinic, we have people signing a specific teletherapy consent that really is specific to the pitfalls or kind of the confidentiality and kind of looser guidelines that exist in tele, because we're not right here in the office with the door shut to know that we're in a confidential environment. And then additionally, one of the things that we do at our clinic is we ask our providers when they get on the session to confirm that our patient is in the same location that we have on file and that their emergency contact haven't changed. And that's really important. If you have a patient who is at safety risk, you need to do a welfare check, or you're concerned, you need to be able to know how to reach them and where they're at, which obviously is much different tele than in person. And I will say one thing, Dr. Storch and I have talked a lot about when we worked together at BCM, and we talked about tele and the benefits, is that traditionally I do believe the first session is better in person. And that's just my opinion. I think that in a traditional world, it's nice to be able to get a read on the individual, be able to really assess their stability and make sure they're a fit, because not everybody is a fit for tele. Now, in the world we're in right now, that's not feasible. A lot of us are no longer doing in-person interactions. And so we kind of make do and we triage it appropriately and figure out how to balance it. But that's an important question that I would love to hear actually from you, Dr. Storch, and everyone else as well. But like, what are your thoughts on, forget now, because now it's a requirement, but when we kind of move past this age and we're back to in-person treatment, how do you differentiate somebody who's an appropriate client for tele versus not?
Mm-hmm. Yeah, I think it's a tricky thing. And I agree with you. I think that, frankly, the relationship is broadly important throughout. And you have to weigh kind of the benefits versus the drawbacks. So, one of our challenges, we're doing kind of a mapping of OCD providers in Texas. And not surprisingly, you see that every metropolitan has folks that are capable, but probably not enough. And the rural areas are without. So how do you kind of branch that is the question. And it's a weighing of that. How we are doing new patients is basically just as you would otherwise. It's not as good, but in the current climate, it's the best we can do. And then I think thereafter, you would, again, balance that pro and con of, can I provide access in a safe, effective manner, given the circumstances of the patient. At any point when you are seeing someone, you don't know what's going to happen, which goes back to why you're collecting their information, their address, which is better or worse, as good as their report. But you're doing an evaluation to see, are they a good fit for this level of care? And then from there, you're kind of determining where they end up going next. The ideal is that they try to do it with you. But I do think that, the silver lining within this whole kind of catastrophe is that we will see some changes that are going to be expedited because we're forced to now. One of them will be parity for reimbursement of tele. Another will be that new patients could be done via tele, which I share that belief that it's better in person at first. But I think that will be a change, and this will give us some increased arsenal or tools in our arsenal.
Mm-hmm.
Yeah, Dr. McGrath, Dr. Solomon, thoughts?
It's been interesting in my switch from Amita, where I saw everybody in person, to No CD, where we see everybody through teletherapy, and it's been a very smooth switch, though. I've actually very much enjoyed it, and still, though, I think both of you are right in the sense that every time I meet someone new over teletherapy, there's still something in the back of my head that says, is this person appropriate for this? Because if they're not, then I always keep that thinking cap on of who would they be better off to see if they do need somebody in person. So I never go in with the assumption 100% that this is the only option. I always keep that full arsenal of intensive outpatient, partial hospital, residential, that those are always going to be options as well too.
Mm-hmm. Great.
And I think those are the same options we would keep in mind for any patient we
Yes,
see.
absolutely.
That's really the purpose of an assessment, right? A clinical assessment is not, this is a new client. A clinical assessment is this client appropriate for the level of care I can offer, or is there a better treatment option that I should be referring them to? And we should always be doing that. But it can be more unique over tele, no doubt.
Absolutely.
Well said. Well said. How about working with kids? How can this differ in that context? Dr. Solomon, you want to?
Well, I just wanted to comment on the previous question because it rolls into this. I think what I've learned along the way is that I do a little bit more labor ahead of time in order to kind of pre-screen patients as far as their level of appropriateness for tele, outpatient, whatever that is. And through my portal, usually I'll get a request over email because that's how I streamline mine. And then I have a response to that. I do a 15-minute free consult, and I can usually get an idea whether it's a parent of a child or an adult, a little bit of a sense of if they're going to be absolutely not appropriate. And then I have a lot of measures that I'll use, ruling out, high risk behavior, active suicidal ideation, any of that stuff, and then be able to refer to the appropriate person. But especially with kids, the way I do an intake is I'll have a parent-only session first, and prior to that, I'll have both the child, depending on their age, and the parent fill out self-report measures, and I'll review them prior to the appointment. And so the parents and I speak a lot about what would be the best setting to build rapport, what is their child worried about, personality, likes, dislikes, things like that. So it's a little bit easier to connect. I've found that, getting creative and really getting to know the idea of the kids ahead of time has been really helpful. And it's gone really well. It almost feels better than in person for a lot of kids. but most of the kids I see are really ready for treatment and are already kind of pre-screened and motivated.
It's a great point it raised about doing that pre-screening, and at some point I'll bring back this question of who may or may not be a great fit for this. On the kid front, this is where we really emphasize this parent involvement, and having everyone together, and it gives you an opportunity to engage the family in a unique fashion. I think the effort that we've tried to make, that I've tried to make personally, is find the silver linings within all this. And one of them is that scheduling individuals has never been so easy, because there's nothing else going on. So they actually crave like something. Please, can we schedule with you more, Storch? The other, though, is that it's now given an opportunity to have family members engaged that otherwise wouldn't have been engaged. And as we've already talked about, in the home environment. Dr. McIngvale, kind of building on Dr. Solomon's comments, thoughts about who isn't an ideal fit?
Yeah, I mean, I think there's a couple things. So I think in particular, when you're thinking about children and adolescents, it's often the environment's really important, so is there a place in the household and an opportunity for that child, and maybe that child and a parent, to be able to be present for a session? I think many of us as providers have probably even had sessions where a mom will bring in the child with OCD plus other kids. And while I get it, and sometimes you have to do it, it's not an ideal therapeutic situation, even in the in-person environment, right? You're trying to give treatment and there's other kids. And so it's really important that the atmosphere would be appropriate, and that we have the ability to do an appropriate session, right? If you live in a studio apartment with your significant other and your child, and they're going to be home during a tele-session, don't know that that's appropriate. We aren't going to be able to keep confidentiality. You're probably not going to be really willing to be as open and comfortable. And so we have to certainly be really smart about the environment. But I think certainly active sociality, and again, level of care that's needed. So a question later on that Shoshana raised is, have any of us done an IOP through teletherapy? And actually, we're doing that right now. So at our clinic, our entire IOP programming is now online from 8:45 until 3 p.m. And that includes two ERP blocks that equate to 4 hours with residential counselors and individuals supporting them in that. And then a group every day led by our behavioral therapists, our PhD level clinicians. And, I think that even an IOP, which is a higher level of care, the individuals we will screen for our current virtual IOP is going to look much different than our screening process for our traditional in-person IOP, because our in-person, we may be able to take a little bit higher level of severity or acuity because we have that touch point and we have the ability to kind of manage and be on site, where when it's virtual, you don't. And so, I think someone has to be decently comfortable with technology. I think that they have to be willing to engage. I think the great part about tele over phone, as Dr. McGrath was saying earlier, is there's a really big benefit to being able to see them, right? I can tell if you're not paying attention and you're doing something else the whole time, right? You're multitasking or whatever it might be. I get it. But at the same time, right, we engage you, and we can do that through tele, where on phone you may not be able to. But I think there's a lot of things that would screen someone out, and it's oftentimes about that assessment and the comfortability and kind of figuring out what's going on in the picture to be able to treat them appropriately. Even pedophilia, OCD, and certain types of OCD have had great success when we've transitioned to tele, but the real benefit is not usually, but to me, sometimes can be in person as well.
Great, thank you for those comments. Dr. McGrath, how about kind of hearing from you? So first session, we've heard a bit about kind of pre-screening, trying to find out as much information as you can, whether it be a phone call or measures. In the case of kids, maybe meeting with the parents first. Are there other things that you might do, in that initial session that would be different than if you're seeing someone up front and in person?
Well, Dr. McIngvale brought up a very good point of making sure you know where the person is, right? Which we don't have to do in person. We know where they are. They're in front of us. So, but it's so important when we're doing teletherapy. We even have people just show us their driver's license just because we want to even make sure that that's the person who set up the appointment, that that's the name of the person as well, too. So that I think is so very important. Other things to be concerned about is there someone, as Dr. McIngvale was saying, in the other part of the room? Which, if I think someone is, I'll ask, would you be willing to flash the camera around the room a little bit? Just, is someone giving you coaching from the side? And we've actually seen that where someone was doing that. And so we had to ask them are you comfortable being by yourself? Or we need to get a release of information signed to have this other person in the session too. So there are some of those kinds of things that you just didn't have to think of in one-on-one therapy because you knew who was in the room and who was in front of you, that now you got to think about. So it's a learning curve for all of us, but it's exciting in some ways to learn some of these new things, because I really do think this is going to be the next step in how we're going to do therapy. This is going to change things going forward, and it's just going to be a part of our lexicon from now on, that this is the way people do things, and it's not an odd or strange or a random thing. It will be there. So we have to come up with new normal and decide what our new norm's going to be when we're doing teletherapy, and that we all just accept that this is just the things that we do now. So we identify the person, we know their emergency contact, we have available to us as therapists knowing where you are, because now you could see people all over in a totally different city because you're licensed in the state, right? So I know the emergency contacts in my city, but do I know them in your city? I got to find that out. Where might be the local hospital, or have I tested out or make sure am I comfortable if I call 911 in my city to say I need 911 in this city, and then get linked. And there's just some stuff that's going to be different, but we need to become comfortable with it's almost an exposure for ourselves, shall we say, of learning that there's some new ways that we're going to have to do things too that are out of our comfort zone. But if we want to be successful in this new way of doing things, we're going to have to be stepping out of our own comfort zone and how we've always done therapy before.
That's great. I mean, the point is that your protocols, especially your safety protocols, will have to differ in terms of the actual content and how that looks like. And I don't think that can be underscored. You brought up one thing that I wanted to ask Dr. Solomon, but from that standpoint of payment, when someone's come to our office, it's pretty straightforward. But any kind of tips on how to collect payment, especially without that contact, to kind of avoid the that awkward interaction.
Yeah, absolutely. One thing that I should just piggyback on Dr. McGrath's comments on safety, what I've started doing is having patients show me their physical license, driver's license, and picture, because technically they could sign up and we don't know if they are who they say they are. And that can be a really scary thing. And so just as another added safety measure, just being able to see, I am who I say I am, this is my address. As far as payment, I do everything through my patient portal. The one that I use has, basically the way it works is if they upload a credit card to the secure server, they can then see my calendar and can schedule themselves and fill out all the paperwork, sign the paperwork, and payment. Basically, since I don't take insurance, anytime someone schedules an appointment, it'll automatically generate an invoice with all of the corresponding codes, my NPI number, anything that you would need, and basically a super bill. And all I have to do is press charge after the session. So it is really, really easy. Mm-hmm. There's ways to refund, change your no-show policy. So
great. All right. So we got a couple questions with regards to specific symptom types. So I'll throw this out there for the panel. but talking about engaging individuals with emetophobia, especially those who might be a little bit more reluctant to, with exposures or to go out in public. Any tips for utilizing teletherapy?
Yeah, I mean, I think teletherapy is a perfect opportunity actually to address emetophobia, right? You can eat meals together. I can do it with y'all now, right? But really, it's true, right? You can do exposures around eating and the food activities together. I mean, again, sometimes actually we find that our office actually constrains us, right? It only allows us to go do exposures in so many bathrooms, so many hallways, or at so many places, where really through tele you have an opportunity to expand that. Of course, confidentially, right? We don't want someone on teletherapy with us in Target, like that's not going to be appropriate. But there are ways that we can certainly do actually, I think, a little bit more.
The screen share option is very nice as well, because you can pull up YouTube and just type in 21st birthday parties and just watch people yakking all over the place and share the YouTube experience together. So that's what I've done is I love to screen share YouTube and just pull up great videos of all sorts of different exposure things and watch them together and get the patient's comments about what they thought about the video and everything. So.
Yeah. I see a lot of emetophobia patients, kids and adults. So I actually have something called Vomit Kit that is on my desktop that pops up with different levels of sounds and pictures. And it actually has a quiz about, throwing up. That one's more for kids, but it's, a true or false of, what is this? Why do I get sick? And a psychoeducation portion. So I used to use it in person, and it actually works really much better with screen share and the videos and all of that.
Awesome. Yeah, we'll have to look that up in our spare time, just for fun. So we got a couple questions about the current situation with COVID, and while these may be broader than simply tele, certainly it makes sense to bring up. So one of the questions from Ashley was asking about, what do you do when someone has been exposed to COVID-19, and then what might be one way of supporting them? In this case, by tele, since that's mostly what we're doing, and refraining from ritualizing or to support them more broadly.
Yeah, I mean, I think, again, right, just because someone's been potentially exposed, doesn't mean treatment should change, right? I always say treatment as usual, no matter what, because the reality is that when we're doing OCD treatment, we shouldn't be putting patients at risk. And so I think the reality for most of us is that since the COVID-19 outbreak happened, most of our treatment guidelines changed drastically, right? You can go to IOCDF.org, and they're continuously updating and posting new treatment guidelines that have been edited by individuals like Dr. Storch and others who are on the scientific advisory board. And we're working to update that because treatment protocols have changed, right? Never in my life have I done work with contamination where I've actually approved hand washing or approved wiping down items that come in your house, right? That's not something we would ever say makes sense. We usually say the opposite, right? Touch everything, hug everything, cross-contaminate, and don't avoid. Now we're kind of living in this different world. But Dr. Grayson did a wonderful webinar with us last Monday, and we talked specifically about this. So I certainly recommend watching it. We talked about how to do exposures in this era. And one of the things I love that he said is, when you come in your house, you wash your hands, you clean your items, but then it's game on, right? At that point, it's ERP as usual. We are in your house, we're doing exposures, and we are going to work on OCD. And I think that's a really great point for us to remember, is that yes, of course, there's going to be uncertainty, and they're going to need a little bit more supportive therapy right now. And we may have to kind of really do some scripts and exposures around, you may or may not have been contaminated. You may or may not have coronavirus or have COVID-19. And the reality is that we don't know, they don't know. And we're just teaching them to live with that uncertainty. But the OCD work shouldn't really change, right? We're not going to ask them to go potentially contaminate people or go break social distancing, because that wouldn't be safe. But we are certainly still going to do ERP that's effective.
Well said. Very well said. Dr. McGrath.
I've added too that if you've trusted us to do an evidence-based treatment with you, which exposure and response prevention is. We're going to also trust evidence that our CDC has put out, and that's evidence-based treatment as well too. So let's all utilize evidence, right? If we're going to use evidence for treatment, we're also going to use evidence for recommendations. And as Liz said, we don't go above that evidence. That evidence is there. That's our guideline. And then as anything from that, OCD takes over anytime it goes above what that evidence is.
Yeah, I mean, we all know OCD rules aren't normal, right? No one has an OCD hand wash that actually follows CDC guidelines. Usually a CDC guideline hand wash of 20 seconds or whatever it is, that's still an exposure for people with OCD because I have to walk away after that 20 seconds, right? So oftentimes enforcing these new rules are still exposures if they're done the right way, but there's a big difference between OCD rules and norms and then, as Dr. McGrath mentioned, CDC guidelines.
Exactly.
Yeah. Dr. Solomon, thoughts about contamination exposures, kind of on top of this discussion right now, any, tips, things that you might want to share with the audience?
I really agree with what everyone was saying. There's really nothing different. I think the CDC guidelines and anything that is in the house is kind of free for all. One thing being in New York and the extensive amount of cases here when people have been exposed or, may have been exposed and they've recently gone out, I usually am a little bit more cautious when there is someone living in the house that might be immunocompromised and still follow the CDC guidelines. But that idea that once you're home, it's kind of safe to do any type of contamination exposures, I'm a little bit more cautious depending on the situation.
Mm-hmm. Gotcha. And Dr. Solomon, just so you know, there's a lot of enthusiasm for the vomit kit. So hopefully for all of you out there, we'll be able to get a link up in time. And if not, we'll
throw that up there for you.
Yes, we'll throw it up there.
That's like a dad joke. But, all right. But we'll work to get that out there. For the panel, how do you sort through the vast amount of information out there? So, of course, we know that the IOCDF is putting out great information. We have panels like this, Liz, the one you spoke about, where you have an expert like Dr. Grayson on there. How do you sort out, though, that, for example, some people may, really believe the World Health Organization or the CDC, and others struggle a little bit with that. Any tips?
Yeah, we've done most of what we know is that you should really limit your content sourcing or content gathering to one source that's a credible source. You get to choose what that source is. Most of us in the US would recommend the CDC. Globally, we'd recommend the World Health Organization. I wouldn't recommend, news channels. Like, that's not necessarily a credible source, and it gives you too much information. You don't know how to sort through it. And then the second piece is, so you limit your kind of coronavirus guidelines to one credible source, but you also have to limit the amount of time you spend researching and looking at that source, right? So most of us would say probably once a day, maybe twice a day, but no more than that, certainly. But the reality is that you choose one source and you kind of limit the amount of time you really spend understanding, researching, reading from that source.
I had a patient say, I need to stop getting drunk on Corona. So I thought that was pretty good.
That was pretty good. Sorry, Dr. Solomon.
Oh, that's okay. One thing that I've noticed is, besides the actual fear of the illness, I think in the same way that we work with GAD, there's this new fear and valid fear of, financial implications, losing job, new childcare restrictions with having, parenting kids that are home all the time, and especially parents of kids with special needs, just so many other new worries and new ideas besides OCD that have to be addressed, and setting guidelines around those can be another added task in addition to the fear of the illness itself and getting sick or contaminating others.
Yeah, well said. And that leads to another question I've been thinking about is, Dr. McIngvale hit on, in that aspect of that self-care. So don't watch the news too much, kind of monitor that. But at the end of the day, and acknowledging this isn't necessarily about therapy, how do we take care of ourselves? If we burn ourselves out, it won't do anyone any good because we won't be there. Frankly, I think when things are going to be even more challenging, like Dr. Solomon, you were alluding to, and kind of the aftermath. But what are things that you've done for yourself, or would advise people on this call to consider doing? Yeah, Dr. Mack.
All right, I'll go first. I'm terrible at self-care, but I'll figure this out. I like to work. I'm not really somebody who enjoys sitting and relaxing, so it's not really my thing to begin with, but you have to figure out how you're going to take care of yourself. For me, it's usually 5 or 10 minutes. I actually have worked longer hours and harder as my work from home than I've ever worked in my entire life. It's like I get locked in my bedroom because that tends to be like where I keep my little office, just because for confidentiality. And next thing you know, it's 5 o'clock and I haven't even had a sip of water all day, which isn't healthy. So I think, sometimes when you're in this new environment, you've got to set some reminders to just kind of take a second, take a breather, take a break. But you have to figure out what works for you. I've been preaching for the past couple of weeks, and so I'll continue to. For me, it's therapy. I still take my 45 minutes every week and do my own mental health therapy. It's important for me. It's how I maintain my illness and my own progress. I know I'm in a different spot than some other providers, but for me, that's my time. And then it's exercise. Right now, I used to love to go to exercise classes. You can't do that right now, but almost all of the places I attend are doing online stuff that you can do in the morning. And so even if you only have 15 or 20 minutes, for me, it's a schedule, and consistency is critical. Just because you're working from home doesn't mean I can sit at home and eat whatever I want and not care anymore. And that's when things just get really disruptive. And so it's about maintaining a schedule and something that mimics what you would be doing if you were going into an office. For me, that's what's important. And I say, I've been preaching it all week, but I've been telling every patient this, and I believe it. This is not the time to put treatment on hold. And I think we get a lot of questions right now of people saying, okay, well, maybe we'll just take a pause then. We'll wait till you resume. That doesn't make sense. As Dr. Storch said, right now, people have more flexibility for appointments than they've ever had in their life, right? Oh, you need to see my kid at 3, perfect, they're home. You need to see them at 10, no problem. I'll take that break for being their teacher for an hour, right? So take advantage of the opportunity and for, like I said, kind of this home visits and the flexibility. Don't let this be an opportunity to take a break and the potential for symptoms to just increase.
Yeah, those are terrific points. A couple of things I've really tried to do is, within all this is see the silver lining. This is a nightmare. I always kind of flippantly would make a comment of, I'm living the dream when people would ask how I am. Now it's not such a great one, but can we think a little bit about what some of the positives might be? My family and I, my extended family, we're Zooming each other all the time. And so having more contact than ever. And that's a small positive. I think the others we're learning that we can actually be pretty productive working from home. And this might be terrific. Houston traffic might actually, in this aftermath, be slightly less. But within all that, it's maintaining optimism. I think that piece is critical. This is awful, but it will pass. And I think that element has been personally very helpful, and kind of persevering through a difficult time right now. Yeah, Dr. Solomon, Dr. McGrath, thoughts? We have a couple other great questions.
I'm just enjoying not driving 3 hours a day. So that's a wonderful improvement on my life right there. And it has helped me personally to feel more energized. I feel like I'm getting more done, and maybe it's because I'm using some of those 3 hours of working now instead of driving, but I also feel less drained at the end of the day when I've been working at home than I did when I was driving in and driving home and working at the hospital. So that's been very energizing personally for me.
Yeah, like that silver lining. Okay. Dr. Solomon.
Yeah, I think there's two sides of it, pre-COVID and currently. I know for me, having done this for a while, it is really isolating. And that was something that, if I'm working all day and because I see people in different time zones, it's sometimes, late at night and different things. And I can go on a busy day without seeing another person if my schedule with my husband conflicts or something like that. So it really is making sure that you have that social outlet, you have breaks, you are getting out of the house, even though the commute and the annoying stuff isn't there. It's also sometimes the trip to the grocery store pre-COVID is enjoyable. Not so much anymore.
Not so much.
One thing, especially being so quarantined here in New York and have recently myself been sick, so I'm extra careful about leaving. I haven't really left the house except getting into nature, even if it's my backyard, doing something, getting your hands dirty, doing a project that doesn't involve a screen or a TV or anything like that. I think that's important. And using that time, there's a lot more available resources like virtual museum tours, things that we would never usually think to take advantage of that are now free and available. And as really busy professionals, we might not have the time to drive an hour to go to a city and walk around a museum and all of that stuff. So I think there are benefits, like you said, a silver lining, but isolation is one thing that before COVID is something, if you're going to be a primarily teletherapist, it's something that you really do need to have a plan for.
One good piece of advice I got from an eye doctor I know is do some eye exercises, because now we're staring at a screen so much more than we probably ever did. So he's given me a couple of exercises to practice just so that I'm not at the end of the day feeling a headache or that tired eye feeling, that there's some specific places to look and exercise and things. And it's been actually very helpful.
Mm-hmm. Well said. So we have another question from Ashley Enstedt, who's at one point has posted some incredible stuff on CBIT being readily available that have been so helpful to disseminating that approach, as well as OCD specific information. So Ashley's asking pointing out that the physical presence of a therapist can often serve as a safety signal. And Dr. Solomon, I think you kind of hit on this a little bit earlier. But does that kind of distance that teletherapy, telehealth provide, can that be useful? Can that be valuable in clinical application? Yeah, Dr. Solomon, do you want to give birth?
It's been really interesting in different types of OCD themes or exposures, the ability to even, sometimes being present, just doing any sort of exposure, whether you're in the room or you're over a screen. The cool thing about, at least Zoom, I know, is that you can even shut off the camera and let that level of uncertainty be there. And I think there is a lot of stuff that can make it less reassuring. What I do when I work with kids is I work with kids with parents in the room a lot so that they, can really know what's going on and be able to implement between sessions and all of that. But sometimes parents themselves are reassuring. And so I think having the flexibility to go in different rooms, to have parents split off is really helpful.
Good point. Yeah, Dr. McIngvale, thoughts?
I think absolutely. I think that for me, my big thing in treatment, it's not about ERP that I've planned. It's about ERP that you plan, right? That's how you're going to be successful. At the end of the day, you have to wake up and go to bed with yourself as your own therapist, not expecting or relying on us to be there, because we won't be. And the most valuable thing we can teach our patients is how to do ERP on their own and how to take that initiative. And I think teletherapy offers that. I think it puts them in their own environment where you get to say, hey, let's do 3 contamination exposures. You're in your room. What would be 3 things that you think would be helpful? What level, what would be 3 items that are in eyesight that would, be about a level 7 out of 10 out of SUDS. And so it really puts some initiative in their hands and makes them push through. And I also think that when we see that kind of codependence and reliance on us, and we have to start to taper it away, right? That no, you have the tools, you have the ability, I've just taught you it, but you've done the work. It's really critical and really helpful actually in teletherapy to be able to enforce that in a way that's a little bit easier than making that shift in person if you see that reliance. So I personally think it can be a really valuable tool for decreasing that reliance on us. And I think that it also can be a really valuable tool for us to dive right into exposures. One of the questions I saw earlier was that sometimes they find themselves, the sessions are going a lot quicker and they run out of kind of stuff to do. And what I have found actually is a lot of my teletherapy I do in 30-minute increments, because we can be super effective and super helpful doing exposures if we're in your home kind of doing these rapid fire things, and we have the opportunity to touch and work with stuff that we might not have the opportunity to do in session in my office. But at the same time, there's also many patients who require 45 minutes to an hour because they're struggling more and they need more. And so I think it's about what does that patient need and how can you tailor things appropriately. But I will say ERP can be pretty effective and pretty quick through tele. So you do have to be prepared for that.
Mm-hmm. Yeah, I think that it's a great point and a great earlier question. It gives you the opportunity to repeat, to practice, to extend. So while you may be able to kind of get through more trials, it just allows that time for more efficiency, and this might make outcomes even better. We published a paper. It was either 2010 or 2012, and it was really kind of among the first teletherapy programs out there, and we compared it to a waitlist control. And we found that about 86% of our kids did great. What was interesting is that our kids, instead of being from Florida, which is where the study took place, they were from everywhere. And we had someone come from Shanghai, and we just kind of flipped the times. They did it in the evening for morning for us. And so it was speaking to, I think, that issue of dissemination, which was much, much more salient even 10 years ago than it was now. But again, that potential to kind of come in and be as effective or even more effective, given the personalized nature of it. Yeah, Dr. McGrath.
I'm hopeful too that some of our archaic, more licensing laws will be looked at in all of this as well too, and that experts will be available to people, let's say in states that just don't have many but have the need, and so that could be one positive thing that comes out of this as well.
Yeah. Hey, Dr. McGrath, how do you think this will pass, and we're a unified, strong society, and hopefully as a world become a little bit closer than we were before. What do you think the profession might look like? And whenever it is, 6 months from now, 8 months from now. How do you think exposure may or may not be different? Thoughts right now about how you might alter your practice, if at all?
Well, it'll be interesting to see what some of the lasting effects of all of this with exposure be different, and how do we re-expose people? Do we go back to the way we were totally doing exposures for contamination? Will there be a bit of a new norm that's kind of halfway between? I don't know. I think Dr. McIngvale smiling. I agree with you. It's just hard to tell and predict some of that. Here's what I like though. The sense of community that I have noticed between therapists with all of this has just been incredible. And it has been wonderful for opportunities like this to be able to get together with people. And what I'm really excited about is the media focus on the mental health aspect of COVID has been massive. And I'm so excited to see that they're not just looking at this from a physical standpoint, but from a mental health standpoint. So I'm hoping that it helps to raise the bar a little bit more about parity or different things like that with mental health, that finally reporters and people that I've been interviewed by all over the country now are thinking, We can't leave the people with mental health issues behind in this, even though this is a physical issue. I think because of the isolation and everything, everyone is dealing now with some certain types of mental health issues that are going on, at least from stress or anxiety. So it's really raised the bar for people to recognize, let's take more advantage of looking at how we can bring mental health into the discussion. So I'm very excited about it from that point of view.
Mm-hmm. Dr. McIngvale.
Yeah, couldn't agree, more. I think that I remember when Jim Hackett and I in Texas, it was, I think, 2006 or 7, went to the state Senate to fight for mental health parity and, spoke on the behalf of individuals with mental illness and were granted mental health parity, yet, 15, however many years, 13 years later, nothing's really changed, right? We kind of, these laws will pass, but them actually being put into action doesn't always happen. And I think even right now, right, a lot of regulations have been lifted, but not all of them. And certain states are still requiring certain licensure. And those of us in our field, it's mind boggling, right? When OCD is such a specialized service and people who have appropriate training and have the ability to treat OCD tend to be far and few between. Yet we have people in certain areas that we're sitting there saying like, hey, you still have to find somebody locally because we can't help you because of regulations. It's so frustrating. And so I think we can only hope. I think that, I've always said that eventually when stigma isn't attached to mental health anymore, we will treat it the same way we do medical illnesses. And, I have to say in the past 10 years, we've seen amazing strides. I think we can all agree we're not where we want to be, but so many people have been willing to share their stories and speak out about mental health and put, a face to this illness or to the illnesses that exist under that realm. And I think if anything, maybe that's one of the silver lining for those of us in the mental health field for COVID-19 is that it really is going to increase access to appropriate mental health care for our community at large.
Excellent points. Excellent points. We have a final question, unless others want to drop, and then certainly we'll open up to the panel as well. But Andrew has asked about experience with providing teletherapy to those who are actively within the military. Is this an opportunity to increase access to services, especially with the possibility of some element of stigma that many may experience?
I'll say we at NOCD have been having some conversations with various military groups right now to help with this specifically so that it does help to decrease the stigma piece, that someone can find a private place to actually work on this and not even have the stigma of walking into a certain building and being seen by other people wondering why they're going there or something. So I'm very, very excited to start working more with military and people with OCD and to see if we can help with that stigma at all.
Yeah, and one can make the argument that would, be for anyone. On the other hand, when we think about the cost of attending treatment, it's not simply the cost of attending treatment. It's, taking off work. If you live in a place, Dr. McGrath, you mentioned a 3-hour commute, which sounds awful, but it would be worth it to come see you, or see anyone on this panel or on this call. But if we're able to reduce some of that, then it improves quality of life, gives us the same dose of treatment, and so on. So some of the benefits. Dr. McIngvale.
Nope, agree 100%. And I think for a lot of patients, the thing we hear over and over is like, I don't want to start over in treatment, right? You already know me, you've been working with me. And that's one of the things teletherapy can offer. I will say, Andrew, the VA has been doing teletherapy for a long time. And the VA is in a unique situation above all of us, where if you are licensed and you work at the VA, you actually can treat anyone across the nation, right? They have their own regulations. So there's a lot more flexibility for the VA to implement teletherapy, and they certainly do it. So it's happening for sure. And we know it will be successful.
Yeah, for me, because I've worked at a VA and also I'm a military spouse, I think that, things are definitely changing in terms of the view of therapy and what it's like to be a veteran at the VA and receive therapy, because there is a lot of frustration with the outpatient, wait lists and different modes of therapy, especially uniform across different VAs and centers with evidence-based treatment versus different types of counseling. And I think telehealth really has manualized that in the way of creating a protocol for this is teletherapy for, prolonged exposure for PTSD or different things like that. And I think it really has helped decrease the stigma, as well as just how unpleasant it is to be at the VA and online and in a crowded waiting room and all of those other things. It's just so much more available, and hearing it from, the personal side and friends and family really has had good response.
Yeah, well said. Well, it looks like we're nearly closed down with questions. Before we kind of thank our panel members, any last thoughts that you want to share? Dr. McIngvale.
So I'll just say thank you to all of you for your work in the OCD community, and thank you to all of our listeners and everybody who's participated. Please continue to check out IOCDF.org or IOCDF's Facebook page. They are doing webinars and informational seminars almost every day, right? And I think it's a real testament to our ability to kind of team up together and publish content when we know people are wanting it and needing it. And the thing I'll say to providers is hang in there. This is a transition. This is a change, right? For all of us, this is kind of new, and we're trying to figure out how to navigate it. One of the things we didn't talk about today is supervision and team meetings and the way those change through tele, right? But those undoubtedly do for some of us, and we're kind of navigating it and figuring it out. And so we'll all continue to do what's best for our patients, and that's kind of all we can do, and take it day by day until we get back to whatever that new norm is. And I think we all agree we don't know what that'll be.
Mm-hmm. Yeah, Dr. Solomon.
I think, I agree with Liz. And I think my hope is that through all this, that providers will be able to become creative in a way that they haven't before. And then, maybe consider integrating telehealth into their practice in the ways that it does fit in when in-person comes back, because I think there's a place for it, even, when there's not a threat like COVID or anything like that. I think it adds to a practice and can be a really useful tool. And although there's, a learning curve we all went through graduate school and had lots of learning curves, and we just become more appropriate and experienced providers when we go through some of these hardships. So I think hopefully everyone's hanging in there.
Dr. McGrath.
Yeah, and just everyone's got to take care of themselves through all of this, because it's a stressor on us to experience something new if this is new for us. And so we have to take the advice we would give to our patients and make sure that we're taking care of ourselves as well. Well
said. Yeah, echoing all those points. And I want to thank IOCDF for everything that they've done under leadership of Dr. Szymanski and many, many, many incredible staff members who are going above and beyond. This panel for taking a Monday evening at the beginning of what will be another long week for everyone, and then everyone on this call who took time away from bath time, bedtime, whatever it is to spend with us. The OCD community of providers is a very, very close, tight-knit one, and we all remain available to support each other in any way possible. So hang tight, keep giving yourself a break and taking care of yourself, and wish you the best in making it through this, which we all will. So have a good night, everyone.
Great. Thanks.
Thank you.